webinar on rare dysautonomias. Again, my name is Lauren Stiles. I'm the president and founder of Dysautonomia International. I'm also a research assistant professor of neurology at Stony Brook University in New York, where I study autonomic disorders. I'm not a clinician, not an MD, so I'm not going to talk a lot in detail about treatment for rare dysautonomias tonight, because I think each of these diseases I'm going to talk about, you could have a whole lecture just on the treatments for each of the diseases. But I do link to some other resources for people who want more detailed information. I want to start off by reminding everyone today is Rare Disease Day. Rare diseases are not actually that rare. A lot of people have rare diseases. Individually, they're rare, but in total, about 1 in 10 Americans has a rare disease. And on a global population basis, it's about 5% of the population, or 300 million people worldwide. So if you do have a rare disease, it's sometimes can feel kind of isolating and lonely, but you're definitely not alone. There are lots of people who have rare diseases. So these are the rare forms of dysautonomia I'm going to talk about tonight. Some of them you might have heard of. Some of them you might be scratching your head saying, what the heck is that? Which is why we're talking about it. But I want to mention that this is not a complete list of all the rare diseases that can cause dysautonomia. Many rare diseases can impact the autonomic nervous system. But these are some of the diseases that we see more often in the autonomic labs and in our support groups, even though they're still pretty rare. So for somebody who might be new, we have a diverse audience. Sometimes we have doctors tuning in, sometimes we have newly diagnosed patients or caregivers tuning in, and sometimes we have patients who've been doing this for 20 years and can probably give this lecture themselves. But I always review the basics of the autonomic nervous system. So the autonomic nervous system regulates all of your involuntary bodily functions. And some of the most important things like your heart rate, your blood pressure, your digestion of food and drinks through your GI tract, the dilation and constriction of your pupils so you can focus your eyes, your saliva, your tears, your immune system, all sorts of really important stuff. So when people have a problem with their autonomic nervous system, it can cause symptoms throughout their body in a lot of different systems and organs. And it can be hard for doctors to pinpoint the source of that when there's so much going on. Here's a chart. There's a lot of different ways you could break up the way you talk about, the way you classify diagnoses or diseases. This is just one way of looking at autonomic disorders from a book from a few years ago. And so dysautonomia itself, it's not a diagnosis. So if a doctor has told you, Jennifer, you have dysautonomia, you should ask them, what type of dysautonomia do I have? Because a good autonomic specialist will be able to pinpoint the type that you have. They won't leave you with a mystery dysautonomia diagnosis. What type do you have? And if your doctor doesn't know how to pinpoint the type, then you probably need to see, especially if you have a rare form of dysautonomia, it might be helpful to see an autonomic neurologist or one of the major autonomic labs where they study the rare forms of dysautonomia. So the syndromic conditions on the right side of this page are really common, and they're considered syndromes because we don't fully understand what causes them or the sort of biological mechanisms. Although undoubtedly they have biological mechanisms, they're still just being figured out. And there's a little dash between the syndromic conditions and small fiber neuropathies, because many of these syndromes come with a high rate of small fiber neuropathy in these patients and a whole lot of evidence of autoimmunity. But that's not what my lecture is on tonight. We're basically not going to talk about these syndromic conditions because they're all common. On the disease side, we have some rare diseases highlighted in yellow. MSA is one of the first disorders I'll talk about, PAF. And then there's a whole bunch of metabolic, inflammatory, genetic, immune, and mitochondrial related. This is also where you would see occasionally rare disorders. So the first one we're going to talk about is MSA. This is a photo from the MSA Coalition's website. I tried, a lot of times when people give medical lectures, they don't include photos of patients or they black out people's eyes for privacy reasons. But I think it's actually really important to see, what patients look like with different diseases and sort of, how they're affecting people. And so these are all the photos that I've included of patients in the slide lecture are all from public websites where the patients have voluntarily offered themselves up to the world to help educate and teach other people about their disease, which I think is great. So MSA is a rare neurodegenerative central nervous system disorder that causes truly profound autonomic and motor deficits. It impacts about 65,000 Americans. It's synucleinopathy. So what is that? So there's this protein called synuclein that everyone has, but people with MSA and other synucleinopathies have a problem with the way their alpha-synuclein sort of folding an abnormal way, and then sort of it ends up in places where it doesn't belong in your nervous system, in their nerves and in their glia. So when that happens, it can damage the nerves and cause serious problems. So other synucleinopathies include Parkinson's disease, which is not rare, and pure autonomic failure, which is my next condition I'm going to talk about after this one. So people with MSA also lose their dopamine neurons in their brain. And this causes a lot of their motor deficits where they have trouble walking, they have balance issues. MSA typically presents in the 50s, which is younger than Parkinson's disease. I'd say a lot of people with MSA are misdiagnosed as having Parkinson's because it's just a much more common illness that more doctors know about. But there's as more research happens, researchers are coming up with ways to more easily distinguish between Parkinson's and MSA. And one of them is the age. If your patient is 50 years old and they have these symptoms, they're probably more likely to have MSA than Parkinson's, although there are forms of Parkinson's that can occur in young people too. So for MSA, supportive treatments exist, things that help regulate blood pressure and control pain and help with bladder function, but nothing slows down the disease pathology yet, I would say, because there's a lot of research happening. And even though MSA is rare and probably doesn't get as much research funding as Parkinson's, a lot of the research on Parkinson's is going to help people with MSA because the Parkinson's field is full steam ahead looking at drugs that will prevent alpha-synuclein from building up in the nerve fibers and maybe even reverse what's already happened. So I would be hopeful about that. But MSA is it's very serious and it is considered a fatal disorder. Here are the symptoms. These are very similar to a lot of the other symptoms in autonomic disorders, but things that are a little bit unique and not just autonomic is that people with MSA might have difficulty initiating movement. Like if they're standing still, they might have a hard time to start walking. And they also get a sort of muscular rigidity and a body stiffness. This can also be seen in Parkinson's. It's sort of a consequence of the loss of those dopamine neurons. They have snoring and sleep apnea problems, sometimes very severe stridor, which is that sort of like that horrible, scary sound when someone breathes in and their vocal cords are closing up on them. And people with MSA and some other synucleinopathies can actually act out their dreams. And sometimes these are very vivid dreams, and sometimes they are, even in their dreams, maybe getting a little violent with their sleeping partner. So sometimes people have to have adaptive things that help them kind of, make sure that they're not sleepwalking and injuring themselves or injuring someone else in their household. Their voices can change a lot. You might sort of I would say almost a stereotypical sort of elderly person with a very quiet voice and kind of quivering. And obviously there's other things that cause that too, but it is something that is present in MSA. More typical autonomic stuff like bowel and bladder failure, erectile dysfunction in men, because that's controlled by blood flow. And all of the heart rate and blood pressure problems are blood flow related. Cognitive impairment, and I'm not talking about the type of brain fog cognitive impairment that you might see in a younger dysautonomia patient. I'm talking MSA cognitive impairment is more like closer to like a dementia type of cognitive impairment where people have truly lost portions of their cognition. And inappropriate laughing and crying, which doctors would refer to as a pseudobulbar affect. People who would laugh or cry at inappropriate situations, you know, that is sort of like they're laughing, but there's actually nothing funny happening, or they're crying and there's nothing that really should have triggered the crying. And that is comes with, you know, brain damage. Sadly, most MSA patients succumb to the disease 6 to 10 years after their first symptom onset. And very often they're not diagnosed right away. It takes a while to get diagnosed. So it can be very traumatic for the patient and their family to find out they have this, and they might only have a few years to live. So it's really important for people who have MSA and their families to, I would advocate speaking with palliative care doctors very early. Even if you're not ready for palliative care, they can help you plan for your future so that as you become sicker, that your decisions or you've already made your decisions on how you want your care to go, and you've set things up to help your family sort of, you know, handle all the medical needs you're going to have. Which is kind of, you know, it's sad to talk about it, but unfortunately, sometimes doctors don't talk to MSA patients about this and just sort of leave them in the dark. I actually have met MSA patients whose doctors did not even tell them it was a fatal disease. And as a patient, I'd want to know, and I'm sure most people would, even though it's a very hard thing to hear. So MSA patients often don't pass away directly from the MSA, they pass away from complications of the disease, like aspiration pneumonia, which when you aspirate food or drink into your lungs repeated times, you can get very difficult to treat pneumonia. And so people can pass from that. Bladder infections can lead to sepsis, which is a sort of full body blood infection. And sometimes people have pass away from sleep apnea problems or sort of, you know, heart attacks or strokes or things like that that happen as a consequence of blood pressure and sleep apnea problems. Anyone who's listening into this, if you have MSA or you have a loved one with MSA, or you really think you have it, I would encourage you to check out the MSA Coalition. Dysautonomia International offers some basic educational information on our website and some of our educational webinars like this, but the MSA Coalition is really the center point for people with MSA and their doctors and their families. And they have a great annual conference, and they're an organization we've worked with for years. They're really great. So I always send our MSA patients over to the MSA Coalition. Also, I would say if you have, or if doctors told you they think you have MSA, it is absolutely worth it to go see one of the major autonomic labs. They might have clinical trials that you can enroll in for new drugs, or just would be able to give you a more precise level of care to, you know, get the optimum care that you can, because a lot of doctors don't know how to treat this. A regular Parkinson's doctor might know how to treat Parkinson's, but they're not really going to know a lot about MSA. So pure autonomic failure is the next condition I wanted to talk about. It's sort of like MSA light. MSA is more central nervous system synuclein deposition, and PAF is the same type of alpha-synuclein problem in the peripheral nervous system. And it tends to be milder overall, but it is associated with severe orthostatic hypotension. People can live 20 to 30 years or more with PAF. So it's not sort of like the same as MSA where we consider it a fatal disease. Eventually, people with PAF will probably pass from complications of it. But if you're 50 when you get it and you can live another 30 years, it's sort of not necessarily very life limiting. It's more common in men age 60 and up. And so this is a diagram from Mayo Clinic of some of the common symptoms. If you know a lot about dysautonomia, you might recognize a lot of these symptoms and say, well, these are symptoms that are present in other forms of dysautonomia too. But some of the things a little bit unique to PAF or that patients can develop a left ventricular hypertrophy, which is sort of an enlarged heart. And they can also develop impaired renal function. And PAF patients also have low blood pressure when they're standing up and very elevated blood pressure when they're laying down, called supine hypertension. And that can be very difficult for doctors to treat. A subset of people with PAF will go on and progress and develop a central synucleinopathy like Parkinson's, MSA, or dementia with Lewy bodies. And so researchers right now are looking at ways to try to predict who's going to move forward and get a more severe synucleinopathy and who isn't, because right now we don't really have great predictive markers for that. Something that helps distinguish PAF from other autonomic disorders or sort of things like POTS or orthostatic intolerance is that people with pure autonomic failure have low plasma norepinephrine levels. Norepinephrine is the neurotransmitter that your sympathetic nervous system uses to talk to other sympathetic nerves. So people with PAF have low plasma norepinephrine levels and like a lack of sympathetic nervous system activity, whereas people with POTS or like younger person dysautonomia, people will have elevated plasma norepinephrine and a more active sympathetic nervous system. So the next disease I wanted to talk about is autoimmune autonomic ganglionopathy. It is rare. There are a lot of doctors who are kind of diagnosing this in people now who don't really have AAG. They have some sort of other autoimmune dysautonomia. That they're not, the doctor is just using this label because it's a known condition that's autoimmune and it's dysautonomia related. But the strictly defined AAG is rare. Fewer than 1,000 people annually in the US are diagnosed with it. 65% of patients are female. They can range from childhood to older age, but the typical age is sort of in the 50s and up. It's the more common age. It often shows up after a viral infection, and it's sort of a subacute onset. So not like sick one day, not sick the next, or sorry, not sick one day and sick the next, but more like gradual, like, over a few weeks or months. Most patients will have a severe orthostatic hypotension and a GI dysmotility that is typically diarrhea predominant. Typically constipation predominant, but some people have a diarrhea predominant GI dysmotility with AAG. And urinary retention, sluggish pupils in the more severe cases. Sluggish pupils means when the doctor shines the light into your eye, when they come really close to your face and shine that light in your eye, that your pupil is very slow to constrict in response to the light and then slow to kind of open up again when the light is removed. So half of AAG patients have very elevated ganglionic acetylcholine receptor antibodies, GACHR. Sorry, I have a cold and I'm like all brain foggy tonight. Oh, speaking of brain fog, I'm going to the wrong slides. Sorry, guys. So 50% have high titers of these antibodies, and the rest of the AAG patients, like the other half, are seronegative, meaning that they don't have any of the GHCR antibodies. Low titers of these antibodies are found in about 5% of the general population, about 5% of POTS patients, and 5 to 7% of people with other autoimmune or neurological diseases. So for example, Sjogren's, I actually have these antibodies in low titers, not as the cause of my disease, but as sort of like a bystander because I have Sjogren's syndrome, autoimmune dysautonomia type stuff going on. So AAG itself, sorry, I don't know why this keeps going back. AAG itself is often treated with immunotherapy. There haven't been great big clinical trials because it's such a rare disease. There was actually an IVIG clinical trial, and in 2 years, they only enrolled 2 patients. So it's been very hard to study. And of course, those 2 patients, one patient got better from the IVIG and one patient didn't. So that's not a really helpful clinical trial to give us an answer on like what the most effective treatment would be. But generally speaking, it's treated with IVIG, immune suppressants like Rituxan, steroids, plasmapheresis. There's a couple of other immune suppressors used, and a lot of patients require combination therapy. Some cases of AAG are associated with cancers, and when there is an associated cancer, it's called paraneoplastic syndrome or paraneoplastic AAG. And the cancers most often seen in AAG are thymoma and small cell lung cancers. But there's other people who have AAG, sort of more commonly, just an autoimmune form of AAG where there's no cancer present. But I mention this because if you have been diagnosed with AAG, or if your doctor thinks you have it, you do need a careful cancer workup to make sure that you do not, that you have not missed, a lung cancer or some other type of cancer that could be causing the AAG. Sorry, I'm getting lost on my slides, guys. I'm not having such a great night. These are the different ganglia. And so this is the spinal cord. Your brain is up here. Your tailbone is down here at the bottom. And then on both sides of the spine, there are what's called the sympathetic chain. And these are sympathetic ganglia that send out small fiber nerves that go to the organs. And so there's also parasympathetic ganglia that come out of the cranial nerve, sort of at the top of the spine. And at the very bottom of the spine, sort of the sacral nerves down here, there's a couple of parasympathetic nerves that come out. So the reason I have two charts is because this one sort of shows you that the sympathetic chain is on both sides of the spine. And then this one shows you that there's a parasympathetic division as well that just isn't shown on this chart. So sorry if I cause any confusion with two diagrams, but basically I just wanted to show people. So in the sympathetic system, these are the sympathetic ganglia. They're kind of close to the spinal cord, and they send out small fiber nerves to the organs. And the nerves are actually the small fiber nerves from the sympathetic ganglia are actually quite long, but we call them small fibers because they're small diameter, not because they're short in length. Whereas the parasympathetic nerves, there's a much longer preganglionic nerve that comes from the sort of root out to the parasympathetic ganglia. And then the parasympathetic ganglia tends to be right at the end organ, or right very close to it or on it. So there's a difference between the anatomy between the parasympathetic and sympathetic. So people with AAG have, if you sort of, another way of looking at that anatomy is this is the spinal cord. This is just like a diagram. It actually doesn't actually look like this. This is the spinal cord, and there's this preganglionic nerve that comes out of the spinal cord. And right before it gets to the ganglia, there is a sort of a synapse where the acetylcholine coming from upstream from the brain will try to bind to the autonomic ganglia to send a nerve signal. But people who have these ganglionic antibodies, there are acetylcholine receptors on the ganglia that are getting blocked by the antibody so that the message can't get through. It's sort of like, the phone being off the hook or something like that, or no one's picking up because the receptor has blocked the message. So that means the downstream signaling from this autonomic ganglia to all the end organ receptors is going to either be very decreased or no messaging at all. And that's why AAG can cause so many autonomic symptoms. So the next disease I want to talk about is a group of disorders called hereditary and sensory autonomic neuropathies. There are many different types of this. HSAN 1, 2, 3, 4. I think there's also 5 and 6. I can't even keep track of how many there are, but I just wanted to include the concept here. And I'm not going to go into these in detail because these are very rare genetic disorders. They're present. Most of them are present at the time of birth. HSAN1 has a mean age of onset of symptoms at 29 years. But these are pretty rare, and most of these patients have large fiber involvement as well. So their EMGs would be abnormal if you've ever had EMG testing. Another one that I think is sort of interesting is this one, congenital insensitivity to pain with anhidrosis. Anhidrosis just means a lack of sweating. And these patients have basically no sensory nerves or sensory nerve receptors. And so they can't feel pain. Normally as a child, you know, if you touch something hot, it hurts. So you stop touching things that are hot because you've learned, because your sensory nerves, they told your brain, like, don't touch that, that was hot, right? But these children do not have that sensory communication. So they will touch sharp objects without any pain from the cuts they're getting, touch burning hot things without realizing that it's burning hot, and they'll burn themselves. And so what ends up happening is they often develop severe hand and foot deformities or severe injuries that have lost, they lose fingers or toes. They tend to self-mutilate their mouth and their tongue and their face because they have no sensation at all. So it's kind of, it's a very difficult thing to treat, to try to tell a baby not to bite their own lip, But so that's, these are just some of them. But the one most often we hear about in the autonomic world is familial dysautonomia, hereditary sensory and autonomic neuropathy type 3. This is a patient whose mom actually runs the Familial Dysautonomia Foundation. And this is from their website. FD impacts about 300 people worldwide. It's very rare. It's caused by this IKB-KAP gene mutation. And to have FD, you have to inherit this mutation from both parents. So the mutations themselves are actually not that uncommon. About 1 in 27 people of Ashkenazi Jewish ancestry carries one of these mutations. But because there is now genetic testing available, very often in the Jewish community, when two people get married, they might get the sort of Jewish genetic disorder testing to find out what they're carriers of and try to plan, sort of plan their pregnancy to minimize the number of people that are being born with this, because it is a very, very debilitating fatal disorder. So there are not many people being born with this now, at least in developed nations where there's access to genetic testing and such. So FD is progressive. These babies are born. It's sort of very obvious from the time of birth that there is a problem. The babies will have weak muscle tone, sort of like floppy babies, people might call it. And they have trouble suckling from the breast or from a bottle of milk. And they have sort of very erratic heart rate and blood pressure. They can have something called an autonomic crisis, which is where their sympathetic nervous system just kind of runs off the rails and causes profound hypertension that can actually lead to strokes and other really serious problems. They have a decrease in perception of pain and temperature. They tend to have a smaller stature. Some patients with FD have an intellectual disability, not all of them. Some of them, some people with FD can work and can have a normal sort of social life and friends, but they're dealing with a lot of symptom management. Right now, there is very little that can be done to slow down the disease. This genetic mutation causes problems in the synthesis of their nerves, and also in the sort of reparative, regenerative processes that happen throughout your life. So there's some groups that are very helpful for FD patients are the Familial Dysautonomia Foundation and FD Now. They're both, they're separate groups, but they both serve this very small population and really funding great research to try to help the families that are living with this right now. The next condition I was going to talk about is ROHAD. This is actually a cute little girl from my just like the next town over from me here in New York, who was in our local newspaper Newsday. And it stands for rapid onset obesity with hypothalamic dysregulation, hypoventilation, and autonomic dysregulation. So the autonomic piece isn't the entire disease. There's something broader going on, but the autonomic dysfunction is present in all of these kids. And it tends to develop before age 10. And the key feature that a child might be developing this is that they have a sudden, unexplained, dramatic weight gain. 6 to 12, over a period of 6 to 12 months. And then they start developing the hypothalamic dysfunction, the autonomic dysfunction, and respiratory symptoms that often require a tracheotomy or some sort of respiratory breathing support. And the cause of this is not known, but I just wanted to bring it up because that sort of early childhood rapid weight gain followed by the autonomic dysfunction and breathing problems is something that I think more people should know about to help these kids get diagnosed faster. The ROHAD Association is a great organization with lots of resources for these families. This one is Lambert-Eaton myasthenic syndrome. It's a rare autoimmune disease that impacts about 3,000 Americans. It causes lots of muscle weakness, especially in the thigh and pelvic area. 90% of Lems patients have autonomic dysfunction. So it's not considered a form of dysautonomia by itself, because it's not that everyone with Lems has dysautonomia, but a high percentage of these patients have autonomic dysfunction. 60% of Lems patients have a paraneoplastic form of the disease that's associated usually with a small cell lung cancer. And 40% of patients have sort of the autoimmune version of Lems where there's no cancer present. Again, this is another autoimmune neurological disease where if you have it, you need a very thorough cancer workup to make sure that you don't have an associated neoplasm. So the treatment approaches for Lems, first and foremost, if you have the paraneoplastic form, treating the cancer. If that's removing the tumor, radiation, chemo, often with paraneoplastic syndromes, when you get rid of the tumor, the autoimmune stuff that the tumor is causing tends to go away or to get much better. What happens is that these tumors actually have receptors on them that look very much like the normal receptors in your body, of your nervous system. And so your own immune system fights off the cancer, tries to fight off cancer by developing antibodies that are attacking the tumor. But if the tumor has receptors that looks like your nervous system, then that immune system response will also unintentionally target your nervous system receptors that are the same or similar to the tumor receptors that your immune system was trying to get rid of. So treating the cancer is the first and foremost approach to treating this. And then also there are some different drugs. There's been a drug called 3,4-DAP that's been available for a long time for free through a small pharmaceutical company in New Jersey. And then a few years ago, a larger pharma company developed an FDA-approved drug that is very expensive. This is I'm probably not even saying it right, amifepridine or amifepridine, I don't know. That's the pharma drug that is now available. And it's considered, I think, first-line treatment by a lot of medical professional societies because it went through the FDA clinical trials. Pyrostigmine, which is also known as Mestinon, is used in these patients. IVIG, steroids, methotrexate, all the typical sort of autoimmune, immune suppressing, immune modulating drugs. Let's see, keep going. What is the antibody that's present here? So I pulled this little diagram from a journal article. So this is one of those synapses similar to the ganglionic synapse, except this is in a peripheral nerve. This is not at the ganglia. So in Lambert-Eaton myasthenic syndrome, there are voltage-gated calcium channel receptor antibodies that are blocked and preventing the messaging from going in and out of the nerve terminal as it normally would. People hear the word Lambert-Eaton myasthenic syndrome and they think it must be related to myasthenia gravis. So there are a small percentage of people who have both myasthenia gravis and Lambert-Eaton, but it's really a totally different receptor. The myasthenia gravis receptor, antibody receptors, would bind to the acetylcholine receptor, or sometimes these other receptors over here like MuSK. So the acetylcholine coming from the upstream nerve into the synapse to pass the message along to this nerve down here would get blocked by this acetylcholine receptor antibody. Or in Lambert-Eaton, this messaging gets blocked. And there's a different condition called Isaac syndrome, which also has autonomic dysfunction, that is the voltage-gated potassium channel antibodies. So, and actually all three of these can sometimes be associated with neoplasms. So be aware of that. If your doctors have diagnosed you with one of these, make sure you've had a cancer workup. Also of note, these antibodies, if you might be freaking out listening to this, because these antibodies can show up in other dysautonomia patients who don't have Lems and who don't have a neoplasm. So these two, I believe voltage-gated potassium and calcium channel antibodies are on the Mayo Clinic autoimmune dysautonomia screening panel, which a lot of people have done. And so they can come back positive in people who have POTS and other sort of more loosely defined, like orthostatic intolerance, you know. And so when they're low titers, we don't think of that they're causing the disease. I think we definitely need more research to understand, could a lower titer contribute to a milder form of disease, but we don't have that kind of data yet. 10% of Lems patients don't have any known antibody. And thankfully, so if you have the antibody, you're more likely to have a neoplasm. And if you don't have the antibody, you're much less likely to have it associated with a cancer. Let's see. And resources. Lems Aware is a helpful resource. I think that's one of the like pharma companies made a landing page for the patient community. There is actually a Lems support group on Facebook. And there are a couple of, I don't think there's any specific Lems nonprofit, but there are definitely, you know, lots of websites out there with journal articles and other info on Lems. So Fabry disease is a rare disease it's actually a lysosomal storage disorder. And what does that mean, right? So people who have Fabry's, it used to be called Fabry's with the apostrophe S, and now they're getting rid of the S. So I apologize if I keep saying it with the apostrophe S, because that's how I'm used to saying it. So Fabry disease, these patients can develop these angiokeratomas on their skin, these sort of little red dots that look like kind of pretty big petechia that kind of stay permanently on their skin. It's considered rare globally, like 1 in 40,000. But there's actually been some research on children in Italy who had juvenile idiopathic arthritis, and their rate was like 1 in 3,000, which is actually not really that, you know, it's not that rare in those kids. And then interestingly, 89% of Fabry patients meet the diagnostic criteria for hypermobile EDS that was published in 2017. And so Dysautonomia International has been talking with those Fabry researchers and also talking to the EDS researchers and saying, hey, can you screen your hypermobile EDS patients for Fabry? Because we know that Fabry disease causes dysautonomia. So if Fabry causes dysautonomia and is highly associated with EDS, then some of our EDS patients might have undiagnosed Fabry disease. Let's see. So here are the symptoms of Fabry. I pulled this from one of those pharma websites. It's actually a pretty good graphic. People with Fabry have attacks of like profuse, severe neuropathic pain. It usually starts in their hands and feet and then can spread. And it's called the Fabry crisis. And it can be so bad that people end up in the emergency room, and often the doctors don't know what to do for them, especially if they don't know the patient has Fabry. They think this person might be drug seeking or something like that. And they also have a lot of kind of common dysautonomia symptoms like fatigue, impaired sweating, you know, heart problems, a heat and cold intolerance, GI dysmotility problems. But Fabry is a disease that affects all of the organs and systems. So they can get kidney problems, hearing loss is not uncommon. And as I showed you earlier, the skin lesions called angiokeratomas that are these little sort of red dots. So what is actually happening in Fabry is that there's this alpha-gal sort of enzyme. And when you eat food that has natural sugars in it, they go into the lysosome and they get sort of worked on by this enzyme that breaks the sort of helps you digest fats and into different metabolites that end up in your urine or your blood or sort of other functions in your body. And people who have Fabry have this genetic mutation that causes a problem with this enzymatic process. So they basically end up with this fat, this GL3 type of fat, just sort of sitting in their cells and not getting sort of recycled through the body. And over time, this accumulates and damages cells, nervous system cells, vascular cells, kidney cells, etc. The good news is that, so before I get to the good news, I'll tell you the earlier part of the slide. There's over 600 genetic variants to the GLA gene that have been found to associate with Fabry disease. And it tends to be more severe in males who have 2 copies of the bad gene, and then females tend to have generally a milder case. Sometimes people with Fabry have it so mild that they might never get diagnosed. And it has this very wide range of severity of how people are affected. There's an increased risk of heart attack, stroke, and kidney failure in these patients. Also, there's some reports of some of the patients having vascular sort of aortic aneurysms and other kind of dissections of blood vessels, which is something we also see in some types of EDS. So that's really interesting that there could be a connection there. And then the good news is that enzyme replacement therapy can help prevent the progression and may help with reducing pain, sweating, and GI symptoms. And there's a lot of research going on in Fabry to try to get to the root cause and really help these patients get better. There's 3 different Fabry websites here, which are pretty helpful. And we're going to have a whole lecture on Fabry from a real Fabry expert coming up with Dysautonomia International later this year. So the last one I wanted to cover, it's kind of a quirky one, Irrikanji syndrome. So 25 known species of venomous box jellyfish, usually in tropical regions, can cause this pretty nasty sting, as you can see on this person's leg. Most of the cases come from the Great Barrier Reef in like Northern Australia, but it's also been reported in the Caribbean, Florida, Hawaii, and Thailand. Sometimes it's bad enough that it's fatal, but most cases just cause people to be severely ill, requiring hospital care. So the venom from these jellyfish contains a sodium channel activator, which causes a massive release of neurotransmitters like norepinephrine and epinephrine. And these work on your sympathetic nervous system. So this really, really excessive catecholamine surge happens like within a half hour of the jellyfish sting. And it triggers really bad tachycardia, hypertension, severe pain, muscle cramping. And then it's generally followed by like a second wave of symptoms of bad hypotension, pulmonary edema, which is when your lungs fill with fluid, and then potentially life-threatening cardiac complications like arrhythmias or heart attacks even. And so there's this sort of acute autonomic instability that happens and people end up in the hospital. But then some patients actually develop this sort of chronic autonomic dysfunction. And there was one patient in particular who had actually contacted me several years ago. Before I was running Dysautonomia International, I had this blog called Potts Girl. And this guy contacted me, and he was a doctor, and he said, I had been snorkeling on the Great Barrier Reef, and I got a little bit of a sting on my neck from a jellyfish. And now I have I think I have POTS. I have this just really weird autonomic stuff going on. And I said, well, that sounds like this really rare jellyfish thing I heard of once called Irrikanji syndrome. I think you should go to the Mayo Clinic, because they like those kind of weird cases, like if you have like a super rare jellyfish sting and you're a doctor, like they're going to be interested in your case. So sure enough, the patient went to Mayo Clinic and they ended up writing a case report on him that was presented at medical conferences. And this patient had a chronic autonomic dysfunction as a result of his jellyfish sting that when they did certain types of autonomic testing on him, they figured out that he had a segmental autonomic ganglionopathy. So basically one of his autonomic ganglia was near his neck, was where he was stung. And near where he was stung, the autonomic ganglia in that region was like pretty much permanently damaged or long-term damaged. And he presented with orthostatic tachycardia on standing that met the POTS criteria, but the Mayo Clinic doctors didn't want to call it POTS. So they just said he had Irrikanji syndrome. But I'm pretty sure this patient knows that he uses all the same treatments as POTS patients use too. So he had sort of a POTS-like presentation from a jellyfish sting. I've also talked to some other patients from the Gulf of Mexico area, like Louisiana and Texas, who say that their dysautonomia started after a jellyfish sting. So I think this is, it's very rare, but if you meet a post jellyfish sting dysautonomia patient, tell them about Irrikanji syndrome and they can check it out, look it up. These are what these jellyfish look like. They're pretty small. Most of them are smaller than, 2 or 3 centimeters. So they could fit in some parts of the world where there are a lot of dangerous, sharks and jellyfish and stuff. People will swim inside swim nets, like at the beach, but these are so small that they can fit through most swim nets. So look out for, if you see jellyfish that look like this, you might want to get out of the water. So that's it for my talk. I wanted to do some Q&A. So if you have any questions, you can pop them into the chat or into the Q&A feature, and I will try to get through them. Again, I'm not a clinician, so I can't give like specific medical advice to anyone. Let's see. Someone is saying their AAG started with an ovarian teratoma. So that is definitely another type of condition, another type of cancer. Or sometimes teratomas are carcinogenic and sometimes they're not, but they're a tumor. And that is definitely another, anytime someone has an ovarian teratoma, they need a big workup for these sort of paraneoplastic type conditions if they have other symptoms. So here's a question. Would a symptom of AAG be immediate passing out when a person stands or transfers positions, like from a wheelchair to a chair? So that could be a symptom of AAG. That sounds like what you're describing is orthostatic hypotension, like an immediate drop in blood pressure when someone stands up. But orthostatic hypotension can occur in MSA, in PAF, in AAG, and in many, many other types of medical conditions. So it isn't necessarily AAG that's causing the orthostatic hypotension, but if you have blood pressure that's dropping that quickly, that often, I would definitely want to get checked out by an autonomic specialist. Let's see. Oh, someone says, in living kidney donor workups, they have seen undiagnosed Fabry's in the female siblings of males with Fabry's who have already progressed so bad that they need a kidney transplant. So yes, so Fabry tends to affect males worse because it's an X-linked genetic disorder. So men have XX chromosomes and women have XY. So if you have XX and you have this mutation on both copies of your chromosomes, then you're going to have a more severe disease. You're totally lacking this enzyme. If you're XY, you might just have a milder version. And females very often have milder. And for a long time, it was thought that women couldn't even have Fabry. But now we know that they can, and they tend to have it a little bit different and a little bit milder than the males do. With the childhood obesity syndrome, is their weight manageable as they grow up? So unfortunately, ROHAD is often fatal. It's a very severe kind of progressive disease. I don't want to give a false info on this, but I would look it up carefully. I'm pretty sure that a lot of these kids really don't make it to full-grown adulthood because it's so severe. Someone's saying, there are a lot of post-COVID diagnoses of POTS. Do you think this is a true POTS or something different? So if you meet the diagnostic criteria for POTS, then you have true POTS. We've known for a long time that more than half of POTS patients have a post-infectious onset. So even before the word long COVID was in the public vernacular, at Dysautonomia International and at the different autonomic labs we work with, we knew that we were going to see a wave of post-viral syndrome patients who have a post-viral dysautonomia, because that happens with any infection, or can happen with any infection. But I think that every virus has its own unique fingerprint, right? So people with long COVID can have POTS, but they might also have actual organ respiratory damage that doesn't necessarily come with Epstein-Barr, and other viruses that are known to trigger POTS. So yes, I think they have real POTS, but I think there's more than POTS going on in a lot of long COVID patients. Will the transcript be available via email or on the website? I will try to make sure that the transcript is available. And so we actually have a YouTube page that we're still kind of bringing up online. Our YouTube page is live, and there's a bunch of videos on it, but we're trying to get captions in English and in Spanish on all of our YouTube videos. And so eventually, whether the live transcript is ready or not, we will have captions on the videos eventually. Sorry if that helps. Let's see. Okay, so someone is saying, how can I find an autonomic specialist near me? So there are not a lot of them. A lot of us have to travel pretty far to find someone who really has expertise. But the best way to find someone, first, check out dysautonomiainternational.org/doctors, and that will give you a list of sort of more well-known doctors in the field who wanted to be listed on our site and who see a wide variety of dysautonomia patients. But that's not a really long list. There's maybe only 200, 300 doctors in the whole world, and that's not enough for like millions of people that have autonomic disorders. So we also created, in each of the 50 US states, most of the Canadian provinces, and a couple of international groups, we have the regional groups creating their own list of who's helpful in their area. So if you're from New Jersey, you join our New Jersey support group. Not only will you see the doctors listed on our website, but if you go to the New Jersey support group, they'll have their own list of who's helpful in New Jersey. So you can find the support groups at dysautonomiainternational.org/support, and that's where you can find all the support groups we offer. So let me try to get to some of the Q&A questions. I'm sorry if I'm squinting. I think I'm getting old and I have to look more closely at the screen. Is there any genetic relationship between MSA, Parkinson's, and the more common dysautonomias like POTS? My mother has MSA. I have relatives on both sides with Parkinson's, and my son and I have POTS, ME/CFS, and related conditions. It seems a bit much to assume it's a coincidence, but we were told my mother's MSA was not genetic. So I think you ask a really good question, and the answer is we don't know, and we don't think that there's any clear genetic relationship between MSA and non-synucleinopathy type dysautonomias. However, there was a very recent study that came out showing that a subset of POTS patients actually have this alpha-synuclein deposition in their small fiber nerves. It doesn't necessarily mean that they're going to progress to a PAF or an MSA or a Parkinson's, but most research on this marker shows that it doesn't exist in healthy people. So we have actually, when that paper came out, it came out from the Harvard Autonomic Lab, and Dr. Todd Levine, who is a small fiber pathology researcher in Arizona, who sees a lot of POTS patients, we asked them, can you do a long-term study where you look at POTS patients who are young, who have this biomarker, and follow them for 20-something years to see, do they just have POTS, or do they end up developing something more serious down the road? There's a totally separate relationship between Parkinson's disease and Sjogren's, and there's a relationship between POTS and Sjogren's. So I can tell you this from my own family experience. Multiple older relatives who have had or have Parkinson's and Sjogren's. When they were a little bit younger, they had been diagnosed with Sjogren's. And so I have Sjogren's, and I have resisted the urge to find out if I have this alpha-synuclein biomarker, because honestly, it's a little terrifying, because you don't really know what to do with that information if you do have it. But if you have Sjogren's at any point in life, you have a much greater risk of developing Parkinson's when you're older. And so it's possible that those autoimmune mechanisms that show up in young people with POTS and ME/CFS might have some kind of role in long-term old age development of central nervous system disorders. The answer is right now, we don't really know. So that was a long answer for saying I don't know. Let's see. Oh, we got the same question about POTS. So I'm trying not to talk about POTS so much since it's not a rare dysautonomia, but let's see if we can find some non-POTS questions. Am I familiar with in utero exposure to carcinogens? So I know that exists, and I know there's a lot of research on it, but I personally do not have any expertise in that, so I wouldn't feel comfortable commenting. Yes, a friend in Australia is pointing out that if you have AAG in Australia, the government wants clinical studies to prove that you should be able to access IVIG or other immune therapies. But since there are no really good studies, it's very hard to prove efficacy and treatment. That is true pretty much in every country, even if they have different medical approval processes for how you get access to medication. The best thing I can advise is, working with a really top dysautonomia expert from your country and going through the process and trying to appeal it and saying, this is a rare disease. Of course, there isn't any research on this. There's only a couple hundred people in the world who have it. And a lot of drug application programs have sort of an understanding that there's rare diseases that just haven't been studied, and it's certainly not the patient's fault. Someone is asking, if you had whole genome genetic sequencing 3 years ago and no known markers of dysautonomia were found, is it worth retesting now? I would say in general, it's not really worth testing your genetic markers for dysautonomia to begin with, because there's so few genes that have any relationship to dysautonomia. And usually those people are identifiable even when we don't have their genetic testing. They're identifiable based on the type and timing of their presentation, their clinical symptoms. So I would say it's not really worth retesting. I mean, of course, a lot of us are doing genetic sequencing now because it's kind of cool. It's a little bit of a novelty, but also because sometimes you can find helpful information medically. But I think that in terms of like finding a dysautonomia gene, I don't think you're going to find it at this point in time. Let's see. So my son has POTS, but also suffers from very serious muscle twitching, temperature control, nausea, urinary urgency. Does it sound like it's more than POTS? So I can't, I'm not a doctor, so I can't diagnose anyone. And even if I was, it's not right to diagnose people over a a webinar chat. But I would say like that muscle twitching, I would actually ask to get checked out for the voltage gated potassium channel antibodies, because I've actually seen that in a bunch of POTS patients who have like a pretty classic POTS presentation, but with like a ton of muscle twitching and sometimes the development of like muscle knots. They can have those antibodies, and if they do, that might be treatable with some immune therapy if it's severe enough. So that's the best I can say on that. I do think it's important for everyone with POTS to get checked out by a doctor who doesn't just shut you down because you have a POTS diagnosis. I would say getting a POTS diagnosis is like the first in your exploration of what's wrong, and then looking for either underlying diseases or contributing factors. So for example, you might have very low vitamin D. It probably isn't the cause of your POTS, but you're going to have a harder time recovering or improving your symptoms if you have other things like very low D or very low B12 or things like that. So I would want to work with a doctor who's going to look for contributing factors. And I think I have time for like 2 more questions. Is MSA the only type of dysautonomia that affects voice? No, I think most of the more severe, large fiber neuropathy related dysautonomias can do that. And actually Sjogren's syndrome, which is a common autoimmune disease that commonly causes dysautonomia, can also affect the voice. Someone says, please repeat that name again, but I'm not sure what they're asking me to repeat. So if you want to retype in the chat what you're trying to get me to repeat a little bit, or what I was talking about at the time. So here's another POTS question. It's a question about the subtypes of POTS. This person said they've had 3 tilts and they haven't figured out their subtype yet. So, okay, so I would say this is sort of sounds contrarian to what a lot of patients talk about on the support groups, but I would actually say finding out your subtype really doesn't matter because the subtypes aren't unique. The subtypes in POTS are things like neuropathic POTS it used to be called like a subtype. That just means POTS with a small fiber neuropathy. So we have research showing that a majority of people with POTS have a small fiber neuropathy. Hypovolemic POTS is POTS associated with low blood volume. A majority of people with POTS have hypovolemia. So hyperadrenergic POTS is associated with excessive plasma norepinephrine when you're laying down or standing up. And so a majority of POTS patients have that. A majority of POTS patients have mast cell activation syndrome biomarkers. A majority of POTS patients have autoimmune biomarkers. You could go crazy trying to figure out the subtype when right now, the way the research is, we basically know that most of these subtypes contribute to each other or are related to each other, and they can evolve over time. So I've been playing the POTS game for 12 years now and have had, multiple workups over the years. Mostly some of them in the later times were just for research, kind of helping out. But initially told I had hypovolemic POTS. Then we figured out I had neuropathic POTS. Then I became hyperadrenergic. So don't put so much weight on those subtypes. They're not really subtypes. They're just clinical characteristics that most POTS patients have all of the above. And some people maybe they don't have evidence of neuropathy, but they have a hyperadrenergic state and hypovolemia. Okay, so somebody said, on the name of the thing. So there's 2 antibodies. There's voltage-gated potassium channel antibodies, VGKC, K is for potassium, and voltage-gated calcium channel antibodies, VGCC. VGCC is associated with Lems. Voltage-gated potassium channel antibodies, the VGKC, are associated with Isaac syndrome, or what's also called autoimmune neuromyotonia, and it causes lots of muscle twitching. So anyone who's got, and I'm not just talking about that little eye twitch everybody gets like when you're tired or, maybe you're a little bit low on your magnesium, but like people who have really relentless muscle twitching might want to get checked out for that potassium channel, voltage-gated potassium channel antibody. Let's see, a couple more, trying to get through all these questions. Okay, so the mom with the son with the twitching limbs, that's the voltage-gated potassium channel antibody that I was talking about. Sorry if I keep repeating it. They're getting multiple questions about it. Let's see. Okay, this one. How is AAG diagnosed? Okay, so a good autonomic expert will kind of have a sense that you might have AAG just based on your clinical presentation, your symptoms, and sort of how the onset started and your, your symptom profile. But more precisely, they would do formal autonomic testing on you, and you should probably have a pretty bad orthostatic hypotension on the tilt table test, and some GI motility problems and a sluggish pupil. They'll do the pupil, a test called pupillometry that looks at your pupil function and how fast your pupils open and close in response to light. And then most importantly, they'll look for that ganglionic acetylcholine receptor antibody, GACHR. And half of AAG patients will have high titers of that antibody. Seronegative AAG can be diagnosed when you have a patient who has all of the symptoms and presentation kind of look of AAG, but they don't have the specific AAG antibody. That doesn't mean they don't have an antibody. They probably have another antibody we just haven't discovered yet, and we don't have a commercial test for at this time. Someone's asking, are ME/CFS, AAG, and HEDS comorbid? I have all three. So most autonomic experts would say if you have actual AAG, we shouldn't diagnose you with syndromic things like ME/CFS or POTS, because the AAG itself causes profound fatigue and all the autonomic symptoms. So it's sort of like, the way I think of it is, if a patient has migraine, do we diagnose them? Do we tell them you have migraine and you have headache? Or do we just say you have migraine? Because that's like the more specific type of headache that they have. And so a diagnosis like ME/CFS or POTS is kind of a less specific diagnosis than telling someone like the specific autoimmune neurological disorder that they have. Hypermobile EDS, as far as we know from the research data, it's not connected to AAG, but there is research showing that HEDS patients have a higher rate of autoimmune diseases in general. And specifically Sjogren's was on that list, and Sjogren's and AAG have a relationship. There are Sjogren's patients who have the ganglionic antibodies in low titers and some also in high titers. So I wouldn't say that HEDS is definitely related, but it's plausible because it has this higher rate of autoimmune diseases. So, okay, now I swear this is my last one because my husband's probably wondering when I'm gonna go eat dinner. If a patient passes out with standing and transferring to a wheelchair, should they still have tilt table testing? Yes, they should. So when a really good autonomic testing technician will put you on the tilt, and they're not trying to make you faint, believe it or not. It seems like a bit of a torture device, but they're a good tech. They're going to tilt you upright to see what happens to your heart rate and blood pressure. And they can, if they're good at this, they can put you down before you actually faint. But it's important to find out why that person, when you're going from to transferring to a wheelchair, to standing, you want to know for sure, is that a heart rate and blood pressure problem, or is there something else causing this? Or is this person having positional seizures? Are they having some kind of cardiac rhythm problem where their heart is stopping or skipping beats for too long? Anytime someone is having frequent syncope, you definitely want a full tilt table test to try to understand what's happening right before the person passes out, what is happening to the heart rate and blood pressure. Some tilt labs that are less experienced will have a lot of patients fainting on their tilt, which is not fun for the patient. But a really good autonomic lab, that's not their goal. Their goal is just to see what happens before you faint. So, all right, I think I'm going to have to wrap it up, but I thank all of you for tuning in this long and sticking with me. I know I went through a lot of content, so I'll make the slides available. We have other resources on rare autonomic disorders on our Vimeo channel, vimeo.com/dysautonomia. You can find some AAG lectures on there from Dr. Vernino, some synucleinopathy lectures from Mayo Clinic doctors. Dr. Glenn Cook has given a rare dysautonomias lecture in the past that was on fewer disorders, but went a little bit more in depth into the treatment. And if anybody has these rare autonomic disorders, We sometimes diseases are so rare that we don't really have a lot of great educational info on our website about them. But if you have a rare autonomic disorder we don't have on our website, you can reach out and we can try to get you some helpful educational resources. Our email is info@dysautonomiainternational.org. So with that, I'm going to say good night to everyone and have a great evening. Take care.